And we're going to cover heart failure and dysrhythmias. So heart failure is the inability of the heart to maintain enough pumping or cardiac output to satisfy perfusing all organs and tissue in the body. Okay, so that means the heart has to squeeze with enough pressure to push blood into the organs and tissue in the body. So heart failure is the end stage of many cardiac diseases. Which means that there has to be all these heart issues to begin with, and those heart issues add up over time and then eventually lead to heart failure. So that's why it's the end stage. In heart failure, the contracting and relaxing ability of the heart are impaired. Okay, the contracting is the systolic part, and the relaxing is the diastolic. Okay, when you get this impairment, okay, therefore, a backup of blood can occur in the pulmonary venous circulation. Okay, this is fluid overload. Okay, the fluid is blood. Okay, so you get this fluid overload, and they call this congestive heart failure. Okay, congestive is simply fluid buildup. You know, we'll say that if we're stuffy in our nose and all that, we'll say I'm congested. There's all this buildup. Okay, so heart failure affects over 5 million Americans, over 670,000 new cases are diagnosed every year. Coronary heart disease, so these are the blood vessels that actually supply the heart. So coronary heart disease and hypertension causes the majority of heart failure cases. Coronary heart disease can cause endothelial dysfunction. Okay, now keep in mind, if um, if the blood vessel has decreased oxygen and nutrients because of the blockage, so the tube is not delivering 100% oxygen and nutrition and all this healthy stuff to your heart cells. So in other words, the heart cells are experiencing a deprivation of oxygen and all that. Over time, that hurts tissue. So endothelial cells start to die. Ischemia is the lack of oxygen, and an infarct starts to set in. Okay, things to look for or signs and symptoms in a patient with chronic heart issues. So these are things that can lead to future heart failure. Congenital heart defects. So that's stuff you're born with. Valve disorders. So for example, endocarditis that hurts the valves, and rheumatic fever can cause endocarditis. Respiratory disease, anemia, hyperthyroidism, dyspnea, pulmonary edema, and S3 heart sound. Okay, normal is S1 and S2 heart sounds. This is the classic lub dub, but with heart failure or things on its way to heart failure, there's this extra heart sound called S3. Okay, there's also low ejection fraction. This is where the ventricles are not ejecting blood very well. Now keep in mind the ventricles, when they squeeze, they eject blood. The right ventricle to the lungs and the left ventricle to the body. Okay, ejection fraction. You want to be in the green here. Okay, so this is good. This is normal to be in the green. As the heart starts to fail, there'll be a reduced amount of blood that is ejected, and then it can get really low. So that's what the red is indicating. So only about 40% of blood is being pumped out with each squeeze. And so, you want to be upwards of 70%, not down to 40%. Okay, some pictures and other things of some conditions that can lead to heart failure. So aortic stenosis. So stenosis is the narrowing of, so you had a nice big circle or a big opening, and then eventually that opening becomes very small. Okay, so the stenosis can be from calcification and scarring and other damage. High blood pressure, coronary artery disease. So you should have a nice open tube, but then as time goes by, there's this damage and oxidative damage and plaque buildup and all that narrows the lumen, so you're certainly going to have a deprivation of oxygen, which will slowly kill cells over time. So go back to stuff we talked about way back in ANP1. Atoms and molecules, you get enough of those, they make up the organelles. Get enough organelles, and that makes a cell work. And enough cells, then you get tissue. Enough tissue, then you get an organ. So if you want to damage the organ, deprive it of oxygen, and then all those little components inside the cell starts to die, starts to fall apart. Cardiomyopathies. So this one is showing left ventricular hypertrophy. Atrial fibrillation, and diabetes and insulin resistance. Okay, some other things that can contribute to heart failure. Okay, systolic dysfunction reduces heart muscle, which that's the myocardial tissue, reduces heart muscle contraction, and this leads to a decreased ejection fraction. Right, ischemia, which is decreased oxygen and as a result decreased ATP. So this ischemia will lead to gradual heart cell death, which means you get reduced contractility, and that will reduce ejection fraction. Okay, so the loss of oxygen and the loss of ATP and decreased calcium contribute to this reduced ejection fraction. Okay, beta 1 adrenergic receptors have a reduced sensitivity to the sympathetic nervous system, right? So when you're in sympathetics, you're going to release epinephrine and norepinephrine. So the receptors are less sensitive to these catecholamines. They're also less responsive to the sympathetic drug therapy, so the adrenergic drug therapy. And this beta 1 downregulation, or this is beta 1 downregulation, and beta blockers can help improve the ejection fraction. All right, so when we release our catecholamines, right, so your epinephrine, norepinephrine, okay, think about your sympathetic responses. So over here, it should increase heart rate, increase blood pressure when activated. Okay, but if it's inhibited, then you'll have decreased stroke volume, decreased cardiac output, decreased blood pressure. Okay, so those are the beta 1 receptors, and those are found in the heart. Now the beta 2 receptors found in the lungs, and in the lungs, your sympathetic response, you'll get the bronchial dilation because you want more oxygen and all that to get to the lungs. But anyway, we're going to focus on the beta 1s. All right, diastolic failure is a disorder of myocardial relaxation. The left ventricle does not fill properly with blood. During diastole or ventricular relaxation, because remember the heart squeezes, then relaxes, squeezes, then relaxes. Systolic, diastolic. Okay, so the diastolic part, ventricular relaxation, when the ventricles are relaxing, they are filling with blood. Calcium needs to be removed. Now, part of muscle contraction, one of the ingredients for muscle contraction is calcium. So calcium is released from the sarcoplasmic reticulum. Okay, so that should go way back to ANP1. The sarcoplasmic reticulum, we find that in skeletal muscle. Calcium is stored in the SR. And the heart also has sarcoplasmic reticulum where calcium is stored. So when an electrical signal comes in, it's going to force the heart to contract. Calcium is released to help with that contraction, but when it's done, calcium needs to be removed. So calcium is sent back to the heart's sarcoplasmic reticulum, and it's the removal of the calcium that allows the heart's actin and myosin to let go or passively slide apart. Okay, so during a muscle contraction, you want that myosin head to bind to actin, to grab it and pull. That's what shortens the muscle. But at the same time, you want it to let go. So you get the binding and the pulling, but then you need the myosin head to let go, to release, and allow the muscle to slide apart. Low ATP interferes with this calcium removal, and if there's scar tissue or thickening of the ventricular wall, this can also impair filling, which means the heart's relaxing, right? So when you're in diastole, ventricles are relaxing, which means they're filling. All right, so number one here, if there is inadequate cardiac output, okay, then the body tries to compensate by activating the sympathetic nervous system. Okay, so this is your stress or fight or flight nervous system. So think epinephrine, norepinephrine. So you're going to get increased heart rate, increased heart contraction, and activation of the renin, angiotensin, aldosterone mechanism. All right, all this is, this helps okay, these compensations help in the short term. Okay, so if there's inadequate cardiac output, then, which by the way, that's CO, and your formula is stroke volume times heart rate, gives you cardiac output. Okay, so the body will activate its sympathetics to help compensate for that low cardiac output. So it helps in the short term. All right, here's a review of the renin, angiotensin, aldosterone mechanism. Okay, so we have our kidneys, and the kidneys releases renin, And we have the liver, and it makes and releases angiotensinogen. Okay, angiotensinogen is converted into angiotensin 1 because of renin. Okay, angiotensin 1 is converted into angiotensin 2 because of ACE, angiotensin converting enzyme. And ACE comes from the lungs. Okay, so the lungs make and release the ACE. And angiotensin 2 is a vasoconstrictor. All right, so the tubes just went from big and open to smaller. And if the tube is smaller, that's going to increase blood pressure. Okay, when the pump, which is the heart, has to push fluid through really skinny tubes, the pressure has to go up. All right, so that's the job of angiotensin 2. Okay, so what's left is the aldosterone part. All right, so the adrenal glands makes and releases aldosterone. And in the presence of aldosterone, you're going to keep sodium and water. So this increases blood volume, and fluid is heavy. So if you're going to keep fluid, then the pump has to work harder. So that increases blood pressure. All right, second, if there is inadequate cardiac output, then the body tries to compensate by increasing the preload. Okay, so number one is by activating sympathetics, activation of the RAS system. Second is increasing the preload. Okay, by increasing the preload, this is a consequence of low ejection fraction. All right, increasing the preload allows for the Frank-Starling law to kick in, and that is if the volume of blood increases, then in the ventricles, then stroke volume increases. Okay, so in other words, the more blood that you put into the ventricle, the presence of that extra fluid increases the volume. So as a result, stroke volume, and stroke volume is when the heart, how much blood is ejected in one squeeze. Okay, so this increased volume causes the heart myocytes to stretch, okay, or lengthen during diastole. Okay, so when the heart's relaxing, it's filling, so it's lengthening, which results in greater fiber shortening during contraction. So that means it's going to be harder and a more forceful contraction. This increased stroke volume Okay, all that increases stroke volume. So increased volume, increased stroke volume. All right, third thing that happens if there is inadequate cardiac output, the body compensates by hypertrophy of cardiac muscle cells. Okay, this is due to chronic activation of epinephrine, norepinephrine. And as a result, you get an increase in heart cell numbers. Okay, this diagram shows with myocardial injury, you get the chronic activation of different compensating mechanisms. So the hypertrophy, fibrosis, myocyte loss, abnormal energy production, ventricular dilation, which leads to the remodeling. So the tissue is actually changing. And then progressive myocardial injury that can lead to heart failure. All right, heart failure activates your sympathetic nervous system. And when that happens, you get increased contraction and increased heart rate. Then there's the retention of fluid. So increased preload on the heart. And then the heart itself can have increase in ventricle size, myocyte growth, and hypertrophy of the heart. All this increases cardiac output. Okay, so the heart has beta 1 receptor. Okay, beta 1 receptors. And it has angiotensin 2 receptors. Okay, so when there is a binding, which essentially is going to activate these receptors, the trade-off is over time, you're going to increase in cell numbers and increase apoptosis of heart cells. And when apoptosis continues, this is myocardial cell death, and an increased number of cells is an enlarged heart. Okay, heart failure differs depending on which ventricle is damaged. Left ventricle failure is the most common presentation of heart failure. Left ventricular failure can lead to right ventricular failure, and if that happens, then that's called biventricular failure. Okay, bi is 2, so both ventricles are failing. Okay, in order to understand what happens, you have to know your blood flow through the heart. Okay, so you'd have to review that. Quick version is blood comes into the right atrium and then spills into the right ventricle and then goes to the lungs and then goes back to the heart into the left atrium and then spills into the left ventricle and then goes to the body. Okay, I did not include the valves or the names of the tubes, but as far as chambers, that's the order. Okay, so we have forward failure. Okay, forward failure is decreased pumping of blood to the body. All right, so when you think about the heart, when it squeezes, where's the blood going? Okay, well, the left ventricle sends blood to the body, so they consider that the blood is moving forward. From heart to body is moving forward. Okay, so now simultaneously, as blood is entering into the heart from the body to the heart, that's also considered forward movement of the blood. Okay, so if you look at the blood in the body, it's supposed to move in a certain direction. That's forward movement. So if you have forward failure, there's pumping, it's the pumping of blood to the body. Okay, backwards failure is where we get backup of blood in the ventricles due to failure of the ventricles to pump out all the blood. Okay, if so here's the heart. And we have our 4 chambers. The ones we're going to focus on is the right ventricle and the left ventricle. So the right ventricle sends blood to the lungs, and the left ventricle sends blood to the body. Okay, so if the right ventricle has issues, then you're going to get systemic edema. Okay, so as blood is coming in and trying to get into the right ventricle, you get backup of blood. So the blood pools out in this area, right? So the fluid gets pushed out and you can get systemic edema. If the left ventricle, and then you work your way backwards, then that would be pulmonary edema. Okay, well, why? If the left ventricle, think pulmonary edema, well, that's because the lungs right? The lungs send blood to the heart, and if blood is not getting in to the heart because the left ventricle is damaged, then you get backup. So that means the lungs are going to get all plugged up. Okay, so pulmonary edema. All right, forward effects will have a decrease in cardiac output, decreased oxygen and nutrient delivery, decreased perfusion to the brain and kidneys, as well as other organs and tissue in the body. There's a decreased kidney perfusion, leads to decreased urine output, which means increase in fluid retention. Left-sided heart failure is associated with left ventricular infarct and systemic hypertension. The backwards effect of left-sided heart failure may produce pulmonary dysfunction. So that would be congestion and edema. Okay, signs and symptoms. Dyspnea, orthopnea, which is discomfort of breathing when lying down. Cough, rails and crackles due to fluid in the alveoli. So you would pick up on that sound with your stethoscope. So that means you're listening to lung sounds. So that's auscultation of the lungs. Hypoxemia, or low oxygen levels, increased blood pressure, and the patient can present cyanotic, which is a bluish, pale bluish color. This diagram is showing what happens with forward effect versus backwards effect. Okay, acute cardiogenic pulmonary edema. Okay, you'll notice, well, first of all, pulmonary, so that's lung, edema, so fluid buildup. Acute means it's happening right now, and that's because something's wrong with the heart now affecting the lungs. So acute cardiogenic pulmonary edema. Okay, normal lungs, there should not be any fluid buildup or anything like that. In the lungs over here, you can see all of the fluid starting to accumulate in the lung field. Okay, pulmonary edema. Acute cardiogenic pulmonary edema is a life-threatening condition where fluid accumulates in the lungs due to a weakened left ventricle. The left ventricle is the main pumping chamber of the heart, and when it cannot pump effectively, fluid backs up into the lungs. Causes of this: left ventricular failure due to myocardial infarction or heart valve disease. Okay, so those things can cause that left ventricle to fail. Fluid overload, increased capillary permeability due to inflammation. All right, so you have your little capillaries, right, and there's fluid inside, and that fluid can leak out into the lungs. And the alveoli. Okay, symptoms would be shortness of breath, especially when lying down, wheezing, cough with frothy pink or blood-tinged sputum, chest tightness or pain, anxiety, and agitation. Diagnosis: your physical exam, including rails and wheezing because you're listening to the lungs. A chest x-ray would show fluid in the lungs. An echocardiogram, which is essentially an ultrasound of the heart to assess left ventricle function. And treatment is oxygen therapy, diuretics to remove excess fluid, medications to improve left ventricle function, for example, giving ionotropes and vasodilators, intubation, and mechanical ventilation if necessary. For prognosis with acute cardiopulmonary edema depends on underlying cause and the severity of the condition. So with prompt and appropriate treatment, most patients recover. However, some may experience long-term complications such as chronic heart failure or pulmonary fibrosis. So with prevention, manage underlying heart conditions effectively, avoid fluid overload, treat hypertension and high cholesterol, and maintain a healthy lifestyle. For example, exercise and healthy diet. Okay, with right-sided heart failure, diagram to help visualize that. You're going to get backup of fluid into the body, so there can be ankle swelling. The jugular vein can distend. So as the jugular vein is trying to drain blood ultimately into that right atrium, it can't because of backup, so the vein starts to distend. Fatigue, enlarged liver, enlarged spleen. Ascites, so fluid starts to accumulate in the stomach area. Okay, right-sided heart failure occurs when the right ventricle of the heart cannot pump blood effectively to the lungs. All right, so going back to our chambers, that right ventricle sends blood to the lungs. Okay, causes of this can be left-sided heart failure, lung disease, so COPD, pulmonary embolism, pulmonary hypertension can cause right-sided heart failure, heart valve disorders, and a congenital heart defect. Okay, symptoms: swelling in the legs, ankles, and feet. So this is lower extremity edema, fatigue, shortness of breath, especially during exertion, ascites, which is fluid buildup in the abdomen, increased urination at night, indigestion, right upper quadrant pain, and organs can increase in size, such as the liver, spleen, and kidneys. Diagnosis is a physical exam, so you can palpate, percuss, looking for enlarged organs, auscultate using your stethoscope, an EKG, chest x-ray, an echocardiogram, so that's an ultrasound of the heart, can help with diagnosis. Okay, treatment: medications like diuretics, angiotensin converting enzyme inhibitors, beta blockers, and then lifestyle changes such as weight loss, stop smoking, and go easy on consumption of sodium. Surgery if a valve needs to be repaired or replaced, or a heart-assisted device in severe cases. Pacemaker would be an example of that. A prognosis for right-sided heart failure depends on the underlying cause and severity of the condition. With proper treatment, many people can live a full and active life. One of the things that can occur with right-sided heart failure is cor pulmonale. And this is a type of pulmonary hypertension, or hypertension in the pulmonary arteries. Okay, the American Heart Association breaks things down into different stages. Okay, we have stage A. So this is at risk for heart failure. So essentially, these are where the person has pre-existing conditions but no heart failure signs and symptoms. Okay, so for example, they have hypertension, they have diabetes, they are obese, they have some sort of genetic issue with the heart. Okay, so they have the pre-existing condition, but no signs and symptoms yet. They're just at risk for heart failure. So that would be stage A. Stage B is they have pre-existing conditions plus one of the following. Okay, so one of the following would be an actual structural heart disease, or increased filling pressure, okay, or the increased natriuretic peptide levels. Okay, in stage C, in this one, they have the pre-existing and exercise hurts. But okay at rest. Okay, so when they're not exercising, they're fine. There's no pain, nothing like that. But when they start exercising, it hurts. Okay, that's stage C. And then in stage D, they have the pre-existings and exercise hurts and hurts at rest. Okay, so that would be stage D, advanced heart failure. Okay, congestive heart failure, some treatments. So treat any underlying cause or precipitating factors, so diet modifications, diet and lifestyle modifications, adequate rest, mild exercise, stop drinking, stop smoking, adequate oxygen. Medications may be diuretics, ACE inhibitors, angiotensin receptor blockers, beta blockers, glycosides. Okay, they may need surgery, such as an angioplasty, or bypass surgery or valve replacement. And then as far as devices, any kind of implant such as a pacemaker, Okay, a ventricular assisted device. Okay, so these are some treatments for congestive heart failure. All right, cardiac dysrhythmias, also known as an arrhythmia. Okay, so with dysrhythmias, it is improper beating of the heart, whether irregular, too fast, or too slow. Cardiac arrhythmias occur when electrical impulses in the heart do not work properly. There may be no symptoms, so everything's mild enough where a person just doesn't feel anything, or symptoms may include a fluttering in the chest, chest pain, fainting, or dizziness. If needed, treatment includes anti-arrhythmic drugs, medical procedures, implantable devices, and surgery. In general, heart arrhythmias are grouped by the speed of the heart rate. For example, tachycardia is a fast heartbeat greater than 100 beats per minute. Bradycardia is a slow heartbeat where the heart rate is less than 60 beats per minute. There is an exception to take into consideration if the clinic is on the 7th floor and that patient took the steps to get up to the clinic and they got right back there and you did heart rate and blood pressure, like that would be something to take into consideration. Did they exercise right before they came in? Or is the person very fit, like a triathlete, for example? Well, they're going to have a low resting heart rate because of the level of their fitness. So those are just some things to take into consideration with tachy and bradycardia. Atrial fibrillation, also known as AFib. Okay, so we're dealing with the top chambers of the heart, right? So the top chambers are the atria. The bottom chambers are the ventricles. So this is where the heart is beating rapid and uncoordinated. AFib may be temporary, may start and stop on its own. And AFib has been linked to stroke. An atrial flutter. So atrial flutter is similar to AFib, but the heartbeats are more organized. And supraventricular tachycardia. So this is on top of the ventricles, supraventricular tachycardia. This includes irregular heartbeats that start above, so there's your supra, above the lower heart chambers, which are the ventricles. Okay, supraventricular tachycardia causes episodes of a pounding heartbeat that start and stop suddenly. Okay, then there's ventricular fibrillation. So this is the rapid, uncoordinated quivering of the ventricles. This is a serious problem that can lead to death if a regular heart rhythm isn't restored within minutes. Most people with ventricular fibrillation have an underlying heart disease or a serious injury. Okay, ventricular tachycardia. Okay, so the tachycardia is letting you know that it is a fast or rapid heart rate that starts with a faulty electrical signal. The rapid heart rate does not let the ventricles properly fill with blood, so the heart may not be able to pump enough blood to the body. Okay, bradycardia is a heart rate below 60 beats per minute. If the heart rate is too low, then the heart isn't pumping enough blood. Okay, sick sinus syndrome. The sinus nodes set the pace of the heart. Okay, so going back to the SA node, okay, that electrical signal comes in. And if the node is not working properly, the heart may switch between too low and too fast. Sick sinus syndrome can be caused by scarring near the sinus node that slows, disrupts, or blocks heartbeat signals. A conduction block is a block of the heart's electrical pathways, can cause the signals that trigger the heartbeat to slow down or stop. Some blocks may cause no symptoms. Others may cause a skip beat or slow heartbeats. Premature heartbeats are extra beats that occur one at a time, sometimes in patterns that alternate with a regular heartbeat. So on EKG, you'll see a normal heartbeat followed by a change in the EKG wave, followed by normal, and so on. If the extra beat comes from the top chambers of the heart, that would be premature atrial contractions. Atria are the chambers on top of the heart. If they come from the bottom, so the chambers on the bottom of the heart are the ventricles, so that would be premature ventricular contraction. And this is where that P, Q, R, S, and T wave formula will come in handy, keeping the P wave by itself, atrial depolarization, QRS by itself, ventricular depolarization, and then the T wave, ventricular repolarization. A premature heartbeat may feel like your heart skipped. A beat, these extra beats are usually not a concern. Premature heartbeats may occur when resting. Stress, heavy exercise, use of stimulants such as caffeine, nicotine may also cause premature heartbeats. Okay, symptoms. A heart arrhythmia may not cause any symptoms. The irregular heartbeat may be noticed during a health checkup. Symptoms of arrhythmias may include a fluttering, pounding, or racing feeling in the chest, a fast heartbeat, a slow heartbeat, chest pain, shortness of breath. Other symptoms may include anxiety, feeling tired, lightheadedness or dizziness, sweating, fainting, or almost fainting. Some things can change how electrical signals travel through the heart and cause arrhythmias. They include a heart attack or scarring from a previous heart attack, blocked arteries in the heart, that would be coronary artery disease, changes to the heart structure because of cardiomyopathy, diabetes, high blood pressure, infections. An example would be COVID. active or underactive thyroid glands, sleep apnea, some medications, so that would be side effect of medications, drinking too much alcohol or caffeine, illegal drugs or drug misuse, genetics, smoking, stress or anxiety can cause arrhythmias. Things that increase the risk of heart arrhythmias include coronary artery disease, previous surgeries, narrowed heart arteries, heart attack, valve disease, heart failure, heart muscle problems, so that's cardiomyopathy. High blood pressure, so this condition increases the risk of developing coronary artery disease because of the bounding. So a blood vessel, when you push fluid through a tube, that blood vessel will expand, right? So, and it does that, 60 to 100 times per minute. That constant stretching can start to create micro tears on the inside of the tube, and that can lead to repair of the artery, which means plaque buildup and all that stuff. So the heart itself, the walls of the chamber of the heart can become damaged, so thick. Heart problems can be from birth, called congenital. Heart defects, thyroid disease, obstructive sleep apnea. That condition causes pauses in breathing during sleep. It can lead to slow heartbeat and irregular heartbeats, including fibrillations. Electrolyte imbalances, so sodium, potassium, calcium, magnesium. So they can be too low or too high, so you can have too many of the electrolytes or not enough of. Okay, some medications and supplements can cause arrhythmias, excessive alcohol use, caffeine, nicotine, or illegal drugs. Okay, diagnosis of arrhythmias. So an exam is done, a history is taken, and the use of EKGs can help to determine your arrhythmias and other heart issues. A Holter monitor, so this is a portable EKG device. Can be worn for a day or more. Sometimes people will wear them for like a week, and it records the heart activity. Event recorder, it's a portable EKG device worn up to 30 days to take assessments of the heart. An echocardiogram, this uses sound waves, so in other words, ultrasound, to take pictures of the heart. This is a really good test, something I recommend everybody get, especially once you hit 40s and up, even just for preventative, just to know. You don't have to have an heart issue, just go get an echocardiogram, see where you're at. I mean, why wait till you have all these crazy symptoms before we finally get an exam? Implantable loop recorder. So this records and monitors electrical activity of the heart to find irregular heart rhythms. A stress test. Some arrhythmias are triggered or worse by exercise. So you'll be hooked up to the EKG leads. They'll put you on a treadmill or a Stairmaster type thing. So they're going to exercise you, get the heart rate up. A tilt table test. I actually have one of these in my office. It's mechanical, so it mechanically brings you up and down. One thing you're looking for is as the table's coming up, the heart rate and blood pressure change as you lie flat on the table, and then the table is tilted up to a standing position. And that one you have to be careful, because once that you bring them up to a standing position, if they're going to pass out, you need to be ready for that. You do not want them to fall and hit anything. Electrophysiological tests and mapping, also called an EP study, can look for arrhythmias. Okay, this is usually done in the hospital, where these flexible tubes are put through the blood vessels, usually inserted through the groin area, and they'll route the wires all the way up into, or the tubes all the way up into the heart. And then there's sensors in there that record the electrical activity. Okay, treatment depends on if they have brady or tachycardia. Some arrhythmias do not need treatments. So sometimes it's diet and lifestyle changes, vagal maneuvers, so in other words, relaxation. Okay, the vagus nerve, which is cranial nerve 10, is a very strong parasympathetic nerve, which means when you do the vagal maneuvers, you can tap into the calming part of your nervous system, which would balance out the heart rate. Medications can be used. Okay, other treatments. So there's your vagal maneuvers that can slow the heart rate. Cardioversions, so paddles or patches on the chest, are used to give an electric shock to help reset the rhythm. Okay, with surgeries, a cardiac catheter ablation, or just simply an ablation, is an option. A pacemaker. Okay, with a catheter ablation, the catheters are put into a blood vessel to the heart, and a pacemaker allows a pretty consistent electrical tick to make that SA node behave properly. Okay, an implantable cardioverter defibrillator is placed under the skin near the collarbone area, that also sends out low or high energy shocks to reset the heart rhythm. Okay, the maze procedure, where a surgeon makes tiny cuts in the upper half of the heart to create a pattern of scar tissue. This pattern is called the maze. And the heart signals cannot pass through the scar tissue, so the treatment can block stray electrical activity. Okay, a coronary bypass graft surgery, or just simply a bypass, where a tube bypasses the damage. Okay, you can see the blockage there, so they will bypass the blockage. So in this picture, that's a single, because there's only one tube, or just simply bypass. A double bypass, there'd be two of those tubes. Triple bypass, three of those tubes. Okay, then here's some EKG waves on premature ventricular contraction. Here's another picture of a premature ventricular contraction. So here's normal, P, Q, R, S, and T wave. Okay, but over here on the QRS, the S to T wave segment is uncoordinated, so that is indicative of a PVC. With dysrhythmias or AV blocks, there's a first degree, second degree, and a third degree AV block. Okay, and it's showing the interval between the P and the QRS complex. Okay, it has a certain length in second degree. There's different lengths that are picked up. And then in a third degree, there's a complete dislocation of the P waves. Okay, this picture is showing you just a reminder of we have some nerves that come in and communicate to that SA node that cause the atria to squeeze, and then eventually that signal goes to the AV node, which will cause the ventricles to squeeze. So that's your bundle of His, the right and left bundle branches, and then Purkinje fibers that go up. So that's the electrical pathways of the heart. And then with heart blocks, there's just simply some sort of error in the electrical signal that slows down or creates sporadic or blocked electrical signal. Okay, another diagram letting you see the changes in intervals with first degree, second degree, and third degree. So lengthened time. Whoops, third degree.